Continue with pediatric musculoskeletal disorders. This is part 5, and it will address juvenile arthritis. We used to call it JRA, juvenile rheumatoid arthritis, but not all of them have a positive rheumatoid factor, so now we're just calling it juvenile arthritis, but you'll see it called both ways. We don't really know why children develop this disorder. Thoughts are there can be a genetic factor affecting the human leukocyte antigens. If they can figure this out, we actually have medications that are aimed at these HLAs. It is thought that this is also an autoimmune systemic inflammatory disease. It may be triggered by infection, but the cause of the infection is unknown. What we do know is this is a multi-system disease. It affects connective tissue throughout the body. It can affect the lungs, the eyes, the joints, the kidneys. It's not a good disease. It is also the leading cause of blindness in children. When you look at the span of years, it goes between 2 and 16. That's a lot. It tends to affect girls more than boys. And what we see is synovial membrane inflammation. So when you look at the joints on these hands, you can actually see how swollen the joints have become. And when you feel them, they feel boggy, which is like squishy, but be very careful when you're touching them because they're very painful also. So there's thickening of the villi, and they develop nodules that protrude into the joint cavity, creating a deformity. And eventually it can scar like that. The diagnostic tests that are used are based on the symptoms the child presents with. So we'll do a CBC. In particular, we're looking for an elevation in the white cell count, and we're also looking for an anemia, not because the bone marrow is affected, but they get what we call an anemia of chronic disease. We're going to look at both of the inflammatory markers, the ESR as well as the CRP. And then specific for rheumatologic disorders, we're going to look at the ANA and the rheumatoid factor. For systemic juvenile arthritis, these kids are going to have a fever, and it only comes in the evening. They're feeling okay otherwise. They may have a rash, and it can affect only a few joints to many joints. What we see diagnostically is an elevation of their white count, a decrease in their hematocrit, the CRP is elevated, the ANA and the rheumatoid factor are negative. If the ANA is positive, it's most likely what we call a Posse articular type. And if the rheumatoid factor is positive, this usually is a sign that the juvenile arthritis is transitioning into adult rheumatoid arthritis. Posse articular juvenile arthritis affects less than 4 joints, and it's in an asymmetric pattern. Typically, rheumatoid arthritis is symmetric joints, but in this Posse articular, it's only going to be one knee, one wrist, one elbow. They also have chronic uveitis, and this is one of the most dangerous aspects of it because it can lead to vision loss. They have the general signs of malaise, low-grade fever, their liver and spleen may or may not be enlarged, and they have generalized lymphadenopathy while they're in an exacerbation phase, so at the beginning and during all of their exacerbations. And this one is linked to the HLA-B27 antigen. And you can see how the joints are affected. So polyarticular, multiple joints, and you can see on this picture, both hands are affected. And it's symmetrical. It's rapid and severe. And when you look at the x-rays, you can see that it looks like little moth holes are present. And this results in permanent injury. So in a polyarticular juvenile arthritis, the SED rate is elevated, but the rheumatoid factor is negative. And you can see the swelling of the knee as well as in the fingers, and you can see the deformity that's already developed in the fingers. These kids need a lot of tender, loving care. So your interventions, parent and patient education. When these kids go home, they need to monitor pain, swelling, mobility, and warmth of the affected joints. And they need to notice if other joints are affected. They still need to be mobile. So they need range of motion and they need to be in proper alignment. Their diet needs to be high in fiber, protein. They need to continue to have increased fluids and calcium because their weight-bearing activities are going to be diminished because of pain. That's what's limiting them. And you don't want them to develop an osteopenia and eventually porosis. We want to promote as many of their normal activities as possible to promote growth and development. When we have these children in the hospital, you need to do a careful assessment of the full body. You do need to look at the joints. You need to look at their range of motion. You need to know how much they can actually utilize their hands, their feet. How much can they walk? Are they debilitated in any way? You need to position them carefully. Elevate the affected joints with pillows. If they have polyarticular arthritis and they're in a lot of pain, medicate them before we reposition them. Promote nutrition. What we don't want them doing is being overweight, but we don't put them on a diet. We want them just eating good foods. Pain management, usually we can get by with nonsteroidal anti-inflammatory drugs. In addition, we give prednisone. So, as the nurse administering NSAIDs and prednisone, what are you on alert for in terms of complications for both of these medications? You need to look this up and consider what other medication would you anticipate being on the medical administration record, and if it isn't there, what should you ask the physician to order? Additional medications include the DMARDs, disease-modifying agents for rheumatoid disease. And this is methotrexate. You may have heard this in the treatment of cancer, but it's excellent for the rheumatoid diseases. The tumor necrosing factor agents have been approved for use in pediatrics, and so you will see Enbrel and Remicade used. So additional management and your goals for your nursing care is to promote normal growth and development. Provide the patient and family education. Provide patient and family coping support. Get them involved with the Juvenile Arthritis Foundation. There's a multitude of resources for them. Maximize their function and prevent deformity. So you want this kid to get up, be active, and mobile. And so our clinical partners, physical therapy and occupational therapy, need to be a part of this child's care. When you're providing nursing care, you want to put this child through range of motion and stretching exercises. Promote activities like swimming, playing piano, which requires the movement of their smaller joints, playing with clay, which promotes movement of the joints as well as muscle development. And then they need to have rest. When they're having an exacerbation, in addition to medications, they can apply heat and alternate with cold, and then neutral positioning of the joints so they're not hyperextended nor are they completely flexed. And we want to try and prevent disease and treatment-related complications as much as possible. So once again, we have collaborative care partners, physical therapy, occupational therapy, and nutrition therapy. The medications, NSAIDs, naproxen, Tolmentin are some of them because you don't have to give them so frequently. They have a long half-life, so they don't have to be given during the middle of the night. The severe form of the disease will be on immunosuppressive drugs and cytotoxic agents. Sometimes they do not work. And then we have newer experimental drugs that might be used are the monoclonal antibodies and the COX-2 inhibitors. And this ends the lecture on juvenile arthritis.